Dr. Tyna Moore, what's going on? Welcome to the show.
Thank you. I'm so excited to be here.
I'm so excited to have you.
Yeah.
I feel like we're going to cover a lot of really interesting stuff today, but let's dive straight into the deep end.
Okay.
Ozempic, Wegovy, GLP-1 agonists, revolutionary drugs or killing us slowly?
Oh, well, I think you'll appreciate this. My initial venture into the data on these was around neurocognitive decline, neurocognitive inflammation. That was where I first started looking. And the data that I found was not what the mainstream media was telling us. So everybody was busy last summer freaking out about weight loss and it's going to kill us and people are having their stomachs paralyzed. And I have a podcast and I wanted to do a segment on Ozempic. So I went into the research mode and because I'm a nerd, and it was not at all what I was hearing anywhere. The functional medicine community seemed to really be having a strong opinion about them as well. You probably saw that. I felt like everybody was just sort of regurgitating the same blog post. I was like, does anyone have an opinion on this that's nuanced? And so anyway, I brought you studies about Alzheimer's disease. So yeah, there's good info here and there's good data happening in animals and in humans.
Fascinating. Yeah, you seem to encounter very polar extreme opinions at both ends of the spectrum. Either that, these drugs are the worst thing ever to happen to society, or that there's actually some really strong, groundbreaking potential for positive health outcomes with their use. So what have you determined based on your research?
Well, if you go tip to toe, there are GLP-1 receptors throughout our entire body, and they do some pretty remarkable things inside the body. And what I'm concluding from everything I've read between animal studies and human studies is that we're seeing a regenerative, a healing, and an anti-inflammatory impact.
Wow, that's big.
On all of these systems. And we don't really have any tools out there. Like when I share with you what I found in here, I was on the plane actually, aggressively highlighting because I was like, I'm going to talk to Max about Alzheimer's. This is what threw me. My grandpa died a horrific death from MS, and I have autoimmune disease, and I have a few of them, and I have one that manifests as really bad pain, back pain. I have psoriatic arthritis, and I also have, when it flares, I get pretty severe neurologic deficits. And so that was where the research started. And I don't understand why the conversation always has to revolve around weight loss and type 2 diabetes. I think it was more of a scenario when they discovered GLP-1, they first were looking at it for neurodegenerative conditions, and then it just happened to do well with type 2 diabetes. And then the weight loss conversation happened, I don't know, years and years later, right? These have been around for 20 some years. The weight loss conversation didn't happen until the last 2 years or so, and people seem to go wild. And I don't entirely know why. I don't know if it's it's like 1980 called, they want their eat more or eat less and move more strategy back, That's clearly not it. Like that's part of it. And I know you're very nuanced in your take on things, so I always appreciate that about you. There's much more to weight loss, but these peptides, independent of their impact on weight and metabolism, have remarkable impacts across the body.
Wow, yeah, I want to get into it.
Yeah.
I mean, I think with a condition like obesity that is so multifactorial, but ultimately comes down to choice, right? I mean, it's not a condition that's primarily genetic. I mean, it might be influenced by genes and socioeconomic factors and the like. There's a whole host of issues that influence one's risk for obesity. But ultimately, I think what has become so inflamed in this, with regard to this drug is that, you see headlines where they're now trying to get these drugs approved for children and adolescents and even pets. I've seen articles
really
suggesting that we put our overweight pets on these drugs.
Yeah.
And it's like, okay, like if my cat's overweight, I'm pretty sure I know how to rectify that situation, right? And it doesn't require a shot.
Yeah.
But that being said, I've always been bullish on them for people as a fail-safe, as a last line of defense, because many people have struggled with yo-yo dieting for their entire lives, and at the end of the day, obesity is still a major problem, and it increases risk for a whole host of health conditions, as is type 2 diabetes. So the fact that we have these drugs available to us, I think, is ultimately a net positive.
I think so. I think the obesity conversation is nuanced, and I think it's over here And I think that the way that they're dosing for it is also over here. So that was the other thing that I stumbled upon was, the horrific side effects we're hearing about. They're not real. They're not nearly as common as the media and the clickbait headlines have led us to believe.
What are the side effects?
Well, you've got the common ones would be nausea, vomiting, diarrhea, gastrointestinal side effects, right? Those are the ones you hear about. They're not at the rates that the media would have you believe. And the dosing strategy around that is really high. So the studies were done in a starting dose that I think is too high for a lot of people. And then they ramp folks up over about 16 weeks. They double the dose essentially every 4 weeks, which is very aggressive. And then they ramp them up to, pretty damn high dose because that's what the study said to do. And I think that model, not great. It's a very pharmacologic model. At the end of the day, these are peptides. So just like you might be familiar with some other peptides we use in the regenerative medicine space, my background is in regenerative medicine. That's what I did for decades in practice. Cool. So BPC 157, TB 500, those are regenerative peptides. For the audience listening, peptides are just strings of amino acids, and strings of peptides make up proteins in its most simplistic form. This has been co-opted by Big Pharma because they tweaked it so that the half-life is longer. The GLP-1 that our body makes lasts maybe an hour or two. The GLP-1 that you get out of a syringe lasts 4 to 7 days. That's the half-life on it. So they tweaked it. Otherwise, it's bioidentical. Well, at least semaglutide is bioidentical to our own natural endogenous GLP-1. But they're taking a signaling peptide hormone. Insulin's a signaling peptide hormone, for instance. If you give somebody a massive dose of that, you'll kill them. So my thinking as I dug into the literature was like, wait, if we've got these potential benefits across all different organ systems, and we've got receptors in all of these different organ systems, then why are we cranking somebody out on a super high dose and essentially overdosing them? I think it's a management and dosing issue is why you're seeing a lot of the problems that people are running into. They're not necessary. I'm not seeing it with any of my patients. So there's a whole, it's almost like two separate conversations. The weight loss conversations over here with these crazy high doses, which some people need, and I get it, and I think that might be an appropriate dosage strategy for them. But over here, we've got a whole slew of potential benefits for folks who might have a family history or a personal history of cardiovascular disease, neurocognitive issues. Like, I want to protect my brain, right? That was really what got me interested. There's also impacts on pain. They're anti-inflammatory in the body. They sit on our immune cells. They sit on our mast cells. They have impacts on conditions like, different mast cell conditions that folks are experiencing when they've got chronic mold illness, et cetera. So that's a more nuanced sort of longevity regenerative approach. It's a more comprehensive program that I would apply these in as just a tool in a tool belt of many other tools. Whereas over here, it's being used as monotherapy. They're cranking people out and we're running into pitfalls.
So you're saying the minimal effective dose of the drug is likely far lower than what's being given to patients today?
Depends. And it depends on what you're going for. So if you're just looking to get some neurocognitive benefit, mood boost, decreases in anxiety. We're seeing that in the literature as well. Things like that. I was going after brain fog. I had really severe brain fog and it was getting worse. And I knew that my autoimmune condition was driving it. And I was a little bit freaked out and I was not handling the day-to-day of, I have a podcast, I run a bunch of stuff, I've got a big team, and I was not meeting the mark. So and I'm metabolically optimized, right? I'm healthy, I'm fit, I lift weights, I eat really well. I have been doing this for decades. I'm not new to this. And so a tiny little dose for me is a whole different story than somebody who, like my father, he's extremely overweight and very diabetic. So he needs a higher dose, but he's still not needing the crazy maximal dose that is popularized in the more standard, approach. So it depends.
Wow.
It depends on the person.
Yeah, I have a family member who's taking it for weight loss reasons, and he says it knocks him out, because it's given once a week.
Yeah.
And on that day, and for 24 to 48 hours after he injects himself, he's got he complains of crazy fatigue.
Oh, no. I don't think any of that's necessary. I mean, think about it though. Like if you overdose any signaling peptide hormone or sex steroid hormone, like any hormone in high doses is going to make somebody feel terrible. So I do think that medicine is catching on. Just in the last few months, I've been seeing data coming out from around the world saying, let's take a more personalized approach. We maybe don't need to dose people up that high. We maybe don't need to take them there that fast. We might want to just approach them. And I'm seeing it when I basically stumbled upon this information and started interviewing every clinician I knew who was using it. And I went straight for my functional medicine and longevity and naturopathic, because I'm a naturopathic doctor as well as a chiropractor. And I was like, who's using this? What are you using it for? What are your dosing strategies? And many of them were dosing very low and slow. They weren't doing it to the tiny increments that I've been playing with. And, and somebody like yourself, like a tiny little dose would be much more appropriate, I think. So they were still using it for weight loss, though. That was the thing. Across the board, it was either weight loss or appetite suppression, or in some cases, though, you've got people who are very thin and fit and they still can't get their blood sugars under control, or they can't get their insulin resistance in check, or maybe they're heading through menopause and that drop in estrogen has created a severe form of insulin resistance out of nowhere. So they were using it in lower doses, but I think the allopathic community at large is where the problem is. And I'm hoping that they're catching on to this, because this is a more personalized approach. Like your family member should not be experiencing that, in my opinion.
Yeah, it's definitely a problem. I mean, he's lost like 35 pounds, which is beneficial for him. But yeah, it's definitely startling, like the degree to which he's complained about it. So you're again fit, normal weight. What inspired the hypothesis that this drug might potentially help with the brain fog that you were experiencing?
It's funny. My husband's an electrician, and I kept telling him, I was like, so it was a culmination. My autoimmune disease was rocking and rolling. I had pushed back pretty hard against the COVID narrative. So I was taking on the censorship industrial complex at full force.
Love it.
So I was very, I was being politically targeted. I had death threats after me. Like, it was a whole thing. So the stress of that was hitting me. COVID knocked me a bit sideways, and I, had some neurocognitive deficits. I always get that with viruses, though, because my nervous system gets hit first. So I was having a little bit of brain fog from that. Menopause was upon me. Perimenopause was happening in real time. And I was like, this is real. Like, I've seen my patients go through this so many times, and this is no joke. And so all of that was happening. I'm strength training. I've been training for well over a decade. Like, I'm doing all the things right. And I kept telling my husband, it's like the breaker in the basement. When the breaker blows, I need somebody to reset the switch. Like, I just felt like I needed something to reset it. And being in the regenerative medicine space, I have access to everything, like things that most humans can't get their hands on. I was doing everything. I was literally doing everything. Bioidentical hormones, exosomes, you name it. And I could not get myself back online, and I could not get my pain down, and I could not get my brain on. And so I started going into this rabbit hole, and I was like, I'm going to try this. Only I'm going to try it at a fraction of the starting dose. And I'm just going to see, and I'm going to titrate up slowly, slow and low, and see what happens. And it was pretty remarkable. And then I would basically gathering a group of people in my head of who I thought it would help, family members, patients, colleagues, friends. And I approached all of them for all different reasons. Only one person was for weight loss. Everybody else had different conditions going on. Maybe it was Crohn's disease or PCOS or neurodivergence, like young woman with neurodivergence who just can't seem to leave the house and hold down a job. Different varieties of people, different ages, different genders. And maybe all of them had a few pounds they could lose. Like, I was getting that middle-aged middle, so I was happy to shed the 15 pounds that COVID stress had put on. But more importantly, I was just trying to figure out, I had to get out of this downward spiral that I was not seeming to abate, and it worked, and it was amazing. And I've seen so many incredible impacts happen. So then I started talking about it, and here we are.
Wow.
That's basically where it came from. And then I started talking to other people who were on it, because I have a decent sized audience and, a couple 100,000 followers. And people started messaging me as I was producing podcast content, telling me their stories, and their stories were incredible. They were like, I went on it for weight, but I ended up going off of all of my antidepressants. Or I went on it for this and it completely reversed my PCOS. And some would say, well, when you lose weight and you get your metabolic health in order, these things should fall into place as well, right? Yeah, I totally agree. So I'm thinking it's both, but there are definitely impacts happening that are independent of the metabolic impact and of the blood sugar regulation and of the weight loss.
You're now seeing people get pregnant. on it,
Yeah.
right? Like it's improving metabolic health to the degree that people who were, I guess previously struggling with fertility, unexpectedly now getting knocked up.
Yeah.
And it's like, it's very interesting.
It's impacting testes. I mean, it's impacting sperm as well. So it's both. It's men and women are being impacted. So they also are peptides in that they heal. They come in and insert themselves where they need to go. This is how peptides work, and they heal up tissues. I think over the long haul, even those on higher doses, so long as they hold on to their muscle mass, and actually, I mean, that's a whole other conversation that we should probably talk about.
Yeah.
But so long as they are doing all the things, as I call it, all the things you talk about, all the things I talk about, they are healing their metabolism. They're healing their insulin signaling. They're healing their insulin reception. Like over the long haul, it's not just a Band-Aid. Like there's an actual healing impact happening on their bodies. And I speculate if done right and titrated down properly, in many people, I think the ability to come off of them is very realistic, and to maintain the weight loss or maintain whatever good benefits they had because they are healing. The way they're being done now, though, like I said, they're getting slammed with a high dose, and then their insurance runs out at 5 or 6 months because it's weight loss only, and they're pulled off of it. So they get up to this crazy high dose, and then it's just completely withdrawn. And the impacts of this peptide on the brain are so profound, I can't even imagine what that would feel like to an individual. And plus, their appetite's been crushed and their muscle mass has been destroyed in the process. It's not actually catabolic at all on the body. I think it's anabolic, and it has really good regenerative impacts on the muscle tissue. But in this case, when you put somebody into severe caloric restriction, just like a low-calorie diet, just like bariatric surgery, they're going to lose the same percentage of muscle mass. And then, as well as I do, they end up totally metabolically devastated. Like that's a much worse situation. Now they're frail and sarcopenic and they have nothing on them.
Skinny fat.
Yeah. And now their metabolism is destroyed. And so I do think, again, that's why I'm saying these are like, in my head, this is like two entirely different conversations.
Yeah. Well, I do want to get into the diet and lifestyle modifications to make these drugs, should you choose to consider them, less risky, right?
Yeah,
and,
for sure.
and to optimize the associated benefits. But what did you find with regard to these drugs and brain health?
Okay, so I got to put on my readers. They haven't improved my eyes yet. My glasses are all dirty, so don't judge me.
No
So
judgment.
this
Safe
is a
space.
I know this is because I wear them on my head because I'm a SoCal girl. This is a study where they looked at a variety of different applications and different studies. So they put it all together. I wouldn't say it was a meta-analysis. They just basically took together, like, here's all the potential of these peptides and what they can do in the body. And they go, it's actually, I'm going to give this to you all highlighted because it's really good. They talk about the pathogenesis of Alzheimer's disease in pretty good detail, but in a nutshell, what they find is that GLP-1 agonists, which is much of what I found just randomly through different studies, but this is all in one place.
Maybe share the title of it so that people can
Sure. The
check it out.
mechanism and efficacy of GLP-1 receptor agonists in the treatment of Alzheimer's disease. So this was done by a Chinese group of researchers. Decrease in neuroinflammation, which is huge, right? And quite literally impacting the microglial cells and how the microglial cells behave, which is huge. Like for me, in my world of pain and regenerative medicine, I'm a chiropractor too, so my neurophysiology is pretty good. And once you get those microglial cells fired up, you probably know this, they don't turn down very well, right? Like
It's the brain's immune system.
Yeah, once they're primed, they're on. There's not a good checks and balances system in there. And once they're on, they're primed. And so it's not that hard to reset them off. And so when you have someone who's either had physical trauma, mental trauma, maybe a bad infection, and they've got that microglial cell activation, birth control pills can do this, just menses onset, pregnancy can do it. Once that microglial cell system is activated, it's a real shit show for people, and it can be very difficult to turn down. And I think, we have a whole society full of microglial cell hyperactivation, and then you add in spike protein and stress. So that's really exciting that we have this potential to normalize and dampen down microglial cell activity, decrease amyloid plaque aggregation, deposition, decreased tau protein hyperphosphorylation. I can't even read my handwriting. Increases in BDNF, decreases in neuronal apoptosis and neurotoxicity, which is basically, for your audience, when the cells decide to blow themselves up. Apoptosis is necessary for cell suicide in a natural way, but we don't want hyperactivation of apoptosis and brain damage.
Indeed.
Increases in autophagy when necessary, increases in synaptic plasticity, which is really exciting. I think that when you put these patients on it, if you do it right, there's an opportunity to introduce new lifestyle habits that maybe they have not been doing before. And because of this potential of neuroplasticity, while their brain, for the audience, what fires together wires together, and we lose the ability to have good neuroplasticity as we age, especially for folks who are not exercising, right? And so if we can potentiate neuroplasticity whilst we are inducing new lifestyle habits, they can wire it in. They can hardwire it better. So there's this window where people can learn new habits. And I'll share a story about my dad after, which is proof to this. And then decreases in oxidative stress. I mean, that's this in a nutshell. There's a whole bunch of more exciting stuff in here, but that's what it's doing. It works basically as a growth factor in the brain, but in a positive way. So I know that you have researched the brain in depth, but I have too. I don't know of anything else that does this in the brain.
It's pretty cool. I
Yeah.
mean, exercise.
Well, yeah, of
but
course.
that's like the holy grail. Like, how can you know?
Yeah, I
how
mean,
can we
that's
bottle-
non-negotiable.
Yeah.
Like I've been beating that drum for 10 years online. Like, you have to be strength training and you have to be exercising. Those types of things are non-negotiable. This is just more of a adjunctive. It's not a substitute for any of it. It's just an adjunctive therapy, in my tool belt when I treat my patients.
Well, yeah. I mean, I'm sure you've at least seen that they're now doing, and I'm not super fluent in this literature at all, but I believe they've achieved phase 1, phase 2 trials where they've sought to see if it could potentially improve cognitive function in patients with, I believe, either MCI, mild cognitive impairment, or even Alzheimer's disease.
Both, I think.
Wow. Yeah, and I think they're now looking to see if it can actually reduce risk for Alzheimer's.
It's looking good. They're in phase 3 trials for this.
Like, they've already found it can reduce cardiovascular events.
Right. So yeah, I pulled this up. Let me get my eyelash out of my eye. I'm having problems here. So yeah, they are looking at it directly for that. So the summary of preclinical, clinical, and real world evidence supportive of a potential role of GLP-1 receptor agonists for treatment of Alzheimer's disease. And basically from randomized controlled trials, we've got a 53% lower risk of all-cause dementia, diagnosis, and type 2 diabetes, because Alzheimer's is type 3 diabetes, right? I mean, if you have type 2 diabetes, your risk for it is fourfold? I mean, it's pretty severe. Reduction in all types of baseline levels, type 2 diabetes, less decline in cognitive function, less decline in cerebral glucose metabolism in Alzheimer's disease, and anti-inflammatory systemic effects, and in the brain too. So the mild cognitive impairment, that's a bigger risk for Alzheimer's disease than even dementia. Am I correct in that?
Mild cognitive impairment is usually, it's like a pre-dementia.
Right. Well, it's like a pre-Alzheimer's, though, from what I was reading, is that even just mild cognitive, which kind of terrified me, actually, when I read it. I was like, wait, if mild cognitive impairment it's such an extreme risk for future Alzheimer's disease risk, more than just frank dementia, which you would think would be like a straight path. But there's so many people out there experiencing mild cognitive impairment that are walking into their 60s and 70s, and some even our age cohort, you're younger than me, but my age cohort is a hot mess. So these little glimmers where you walk in the room and you don't remember what you're in there for, and all of these little harbingers decades earlier. I'm not saying put everybody on GLP-1s. I'm just saying we have to get our metabolic shit together, because this is what's down the line. And I've said this for years. If you're walking the line on poor metabolic health, which most Americans are, you're sitting there for 15, 20 years before you get the magic diagnosis of type 2 diabetes. And all that is a number on a lab where they're like, you've arrived, right? Now you've got type 2. But all of the damage in your microvasculature has been happening that entire time. So your kidneys, your retina, your brain, right? You're going to see. We were always taught you're going to see type 2 diabetes you're going to get probably diagnosed by your eye doctor before anyone else, if your eye doctor's doing a good job, because they're going to see the retinal damage.
Well, people get the diagnosis of prediabetes, and there's probably some degree of relief where they think, oh, thank God I don't have full-blown type 2 diabetes. But prediabetes is essentially type 2 diabetes.
Yes, it's phase 1.
It's phase 1, stage 1, type 2 diabetes.
Yeah.
And insulin resistance is essentially, a prodrome for that.
Right. And so if the cardiovascular disease that is coming with it, in lockstep, doesn't take someone out first, they're looking at dialysis, which is popping up on every corner where I live. There's dialysis clinics everywhere because this is a very profitable condition for a lot of industries, right? Type 2 diabetes is extremely profitable for a lot of industries. At the end of that is dementia or Alzheimer's disease. I mean, at the end of that, you don't know your name and someone's taking care of you, right? If you're lucky enough.
Yeah,
so that's what's happening early on when women are like, oh, I'm just, put on an extra 40 pounds and I don't want to exercise because I don't want to get bulky. I don't want to lift weights. And my mom had Alzheimer's and my dad has diabetes, but it's just in the family. I'm like, pull the chute. This is a red flag. You got to train for this shit. Like, you have to train for menopause and you have to prepare for this in middle age, because I think every woman, as her estrogen drops, is going to walk into metabolic dysfunction. If she doesn't walk in with good muscle and well exercised and well trained, she's going to get metabolic dysfunction, period, because of the drop in estrogen. And it's harder on the tail side of that to, even if they get bioidentical hormone replacement or any kind of hormone replacement, it is so much harder to clean that up when, I'm telling you this from clinical experience and treating a lot of women with hormones, it's nearly impossible. It's like trying to hit a moving target if they're not fit, if they don't have good muscle, if they're not exercising regularly. I know it's a big fad right now on Instagram. There's all of these big influencers talking about the importance of estrogen. And I'm like, not in a hot mess, inflamed body that's metabolically unsound. Not a great idea. Goes down weird pathways that you can't really control as well. And hitting the target on the dose is very difficult in those patients. It's truly like trying to hit a moving target. And when a woman walks in who's fit, who's metabolically optimized, who's healthy, who's doing all the work, you just apply a little hormone and it sweetens the deal. And that's how these peptides are working too. You just apply a little bit and it sweetens the deal. It's not this full throttle, like emergency medicine kind of situation where somebody is allowed to reach that extreme point of extreme obesity or extreme type 2 diabetes. It's preventative.
Are you also generally in favor of HRT?
Yes.
For women, yeah.
Yeah, for men, women, I couldn't imagine not.
Yeah, well, there were many decades where women were afraid of it, right?
Yeah, but the smart ones of us read that study decades ago and realized they used progestins and not progesterone, so we never stopped prescribing. I've been prescribing the whole time. We're all fine. Nobody's died of a heart attack. No one's gotten breast cancer.
I just remember my mom was always terrified of the purported cancer risk.
Yeah, my mom went off it herself, and I recently was like, Mom, I can't even imagine. I cannot imagine the damage that did to a whole generation of women.
Well, we're now living longer than ever before, and at least I believe that to be the case. And so a woman spends much of her life, half of her life at least, a third.
Yeah, a third after menopause.
After menopause.
Yeah, give me the hormones.
Yeah.
Like you're going to have to pry them out of my cold, dead hands. But I've been on hormones since my 30s, like physiologic doses, much like I handle these peptides. We introduced the physiologic dose. I've got men in their 20s that I've had to give testosterone to because they were Canadian and they played hockey and they had multiple head injuries and multiple knockouts, knocked unconscious. And all that head trauma induces low testosterone and low-grade metabolic dysfunction. A lot of TBIs, a lot of traumatic brain injuries induce metabolic dysfunction. So like my dad basically had 2 aneurysms back to back blow. The first one they missed and it continued to bleed, and the second one was a doozer. And then he fell and cracked his head open. It was a mess. He immediately he had to have surgery, but he immediately fell into severe metabolic dysfunction, gained a ton of weight, and basically checked out for the next 20 years. Became massively overweight and diabetic. I told him the whole time, Dad, you got to walk. Dad, you got to eat well. I mean, I preach the stuff online, I live it, and I was relentless. I don't live that far from him. I was relentless on him, and I could not get him to give a damn. And he just descended into obesity, dementia, and extreme physical pain. And then there was, in orthopedic medicine, once they got you, they just keep bringing you back, right? And so there was slews of spinal surgery, on and on. It was a mess. And I basically came to him last winter because turns out GLP-1s have a pretty profound impact on our immune system and are protective against some of the things going around, interestingly. And so I said, look, we're not doing another winter of pneumonia because we live in Oregon and none of us really trust the medical system anymore. And so I'm kind of I'm the one everyone calls because it was pretty scary there for a hot minute, with what was going on. And so I said, we're not doing another winter of pneumonia. You're going on these because he's already got one foot in the grave for sure. He's in his 80s. I mean, every single year, my daughter's like, I don't think Papa's going to be here next winter. Like, I don't think he's going to be here for next Christmas. So we're always home for Christmas. And I said, I'm putting you on these GLP-1s. And he said, no. I've been watching the news and the news says it's bad and it's going to kill me. And I'm like, dude, you're already half dead. Like, this is no life. And so I put him on a very small dose. I went very, very low. He has gastrointestinal issues. We were very careful. Not once have we had any symptoms. And I've got him to half of the standard dose. So he needs a bit more because he's a pretty severe case. And last Sunday, he, for the first time in a decade, went out to brunch with all of us.
Wow.
And he had brunch with all of us.
Wow.
And I was like, thank you, semaglutide. For everyone who wants to bitch at me and hate on me online about it, I'm like, my dad is sitting here and he's functioning, because a lot of people are really mad about this conversation. And I'm like, I think a lot of people are falling for the propaganda again.
Well, what are the risks? What are the purported risks?
Okay, so for real, if you have biliary disease, meaning some kind of gallbladder issue, you have to be very careful, because when you take somebody and you put them on a peptide that's going to slow gastric motility, most of the folks who are sitting at biliary risk happen to be those who are overweight or type 2 diabetic, right? It sludges up your gallbladder. And then if they get put through that traditional dosing strategy, they're going to be having their appetites get crushed. And when you stop eating, your gallbladder sludges up even more. And the potential to throw a stone into your pancreas is real. And that would be pancreatitis. And that is bad. That is very bad. We do not want acute pancreatitis by any means. So that's a potential risk. I think anybody with biliary issues should not avoid them. Just work with somebody intimately who's going to be very responsible to go slow and low with you. The concern with gastroparesis, the number one risk for gastroparesis is type 2 diabetes. So these folks already have hyperglycation of their vagus nerve, and meaning their vagus nerve is sugared up to the point that it's being destroyed slowly and surely over time because of the unmitigated blood sugars. So that group is already sitting at an increased risk, and then they're put on these standard doses where they're cranked out on it. And I think it's throwing people over the edge. That's not a permanent condition. You're not going to have stomach paralysis for the rest of your life like some of these people are reporting. They've even done studies where they pulled them off and gastric motility returned to normal. It just takes a minute for the peptide to leave your system. It takes a few weeks. But unmitigated type 2 diabetes might lead to permanent gastroparesis. The thyroid cancer risk, they're pretty much deciding that isn't a real risk. They have been looking at the data over and over, and just recently they've come out and said, pretty much several organizations have come out and said, we're not that concerned about it. Like, it's not adding up to real risk in humans. But in animals, in rats, they overdose them on super high doses of GLP-1s. These rodents, rats and mice, are prone to a type of thyroid cancer called medullary thyroid cancer. It's very rare in humans because we have different receptors on our thyroid gland. So these animals will spontaneously develop medullary thyroid cancer. There was a higher amount of it in the massive semaglutide or the GLP-1 dose, but also the control group developed spontaneous medullary thyroid cancer. And they're obviously it's black box warning on the drug, and they're cautioning humans who have a history of that type of cancer or any type of thyroid cancer. I would say talk to your doctor. If there's a family history, talk to your doctor. Obviously, be careful. Decide what your risk to benefit ratio is and if that's an appropriate choice for you. The muscle loss conversation, I think we covered, pretty on par percentage-wise of that's lean mass loss as well. People are confusing that. Muscle is part of your lean mass. So of that lean mass loss, it looks like a big number, but that's not all muscle. The other thing that nobody's talking about is that folks who are metabolically unsound, diabetic, obese, have really pathologic muscle, right? And you have had this lovely Dr. Gabrielle Lyonon, who's talked about this at length. Not all muscle is created equal, and metabolically unsound muscle is got a ton of fatty infiltrate. It doesn't fire well. It's not stable. It's really pathologic. It's very insulin resistant. I think that I've said this for decades. I think that insulin resistance starts in the muscle. It starts in the big muscles of the legs and the butt. You know, if your butt goes flat and your legs shrink up and your belly starts growing, you're probably headed down that lovely highway to type 2 diabetes. So these folks are put on super high doses. Who knows if they're being counseled on nutrition? Who knows if they're being counseled to protect their muscle through strength training, through prioritizing their protein macros? Probably not. I don't want to throw all doctors under the bus because I know there's good doctors doing good work. But generally speaking, you know, your average patient is going to be put on these and probably not given a ton of support. And so maybe they're choosing, I don't know what's happening with compliance on there, and maybe they are, and maybe they're just not being compliant. Trying to get patients to strength train is like pulling teeth. I've been there.
Yeah.
I've tried. It's difficult, right? Like, it's hard enough to get our followers to believe us.
Absolutely.
So these folks are put on crazy high doses and they waste away because they're malnourished, and they're potentially just eating less of the already malnourishing food that they were eating before, you know?
It's a big problem.
I don't want to say the garbage, but a lot of folks are living, not even knowing, they're just kind of living off of a chemical shitstorm. And so they just eat less of that, and there's no nutrient density there. So that is not actually the peptide's fault. That's a dosing and management issue or a compliance issue. These peptides are regenerative to the muscle. Like I said, they help hyperperfuse them with additional angiogenesis. They bring in more amino acids. My colleagues who are using them, who are actually pretty fit, I've got some, you know, muscled up guys on these, and they're like, it kind of feels like testosterone. It's kind of anabolic. So I think for the most part, we can agree through looking at the data on animals and humans that it's regenerative and healing and anti-inflammatory to the muscles and to the joints and to the bones. It's not catabolic.
Well, what happened to just prescribing a high protein diet? I mean, eating a high protein diet is a fairly effective way of boosting GLP-1.
I agree. But there's this idea that keeps rolling around in my head, and I've talked to a couple. It's only the other naturopathic doctors who are like, yeah, that makes sense. Most people have gut issues. Most people in our clinics coming through have some kind of leaky gut or compromised gut. So there's a lot of IBS, there's inflammatory bowel disease, there's just atrophy from aging. And I don't necessarily know if everybody's L cells are up for it. So getting the L cells to secrete the GLP-1 is really like the hot conversation right now in the probiotic land, and different nutraceutical companies are coming in trying to create natural, you know, promoters of GLP-1, and they're trying to get, it's like poking a dead horse sometimes, I think. And when I talk to some of these docs I've seen on webinars, they're like, yeah, I am kind of concerned with the actual, like, how are these patients coming to us with, what are their L cell health? Like, what's happening there? And then we're trying to promote it with berberine and high protein, and, you know, there's all different ways to try to stimulate them, but are they even working? And we have data showing that those who are obese, have fatty liver, and are type 2 diabetic have really low naturally occurring GLP-1. And it's kind of this chicken and egg. I think part of it is probably that their gut health is devastated, but high insulin levels due to this chronic insulin resistance will drive down GLP-1 levels. So they're stuck in this loop. So I totally agree with you. I think the high protein diet is also non-negotiable, but my argument is that maybe we give them a leg up, but we do so responsibly.
Yeah, it's like a jump start.
And elegantly.
Yeah. Very interesting. So do you think that they should be putting essentially semaglutide in the drinking water?
No. No, but I think that, so my dad, okay, let's go back to my dad. He's out to brunch with us, and he starts talking to me about how he wants to start walking. And I was like, what, my dad wants to move? Like, this is a thing?
It's exciting.
Well, I think that I've treated a lot of patients, and there's folks who are stuck. They're so stuck.
Oh, I get it. My dad's the same way.
Yeah. So it's like, where do you decide that you're going to apply a therapeutic? And again, this is the conversation over here. And if we go back to over here, where I'm thinking about things preventatively, I do think that there is a place for them in somebody who has maybe a family history of neurocognitive issues or a family history of cardiovascular disease. Because like that SELECT trial at the end of 2023, the heart disease one, they looked at overweight, middle-aged people who did not have type 2 diabetes. I would argue that those people probably were on the path. I mean, if they gave them enough time or they actually looked at some more sensitive markers, they probably did have insulin resistance, but they didn't have diagnosed type 2 diabetes. And there was a 20% reduction in cardiovascular, severe cardiovascular outcomes. But then everybody argued, well, maybe it was because they lost weight, right? And everybody would do better with their cardiovascular markers if they lost weight, which is totally true. But they reevaluated that data recently and they followed up with these folks and it was independent of the weight loss. So I do think that there's a place strategically done in the preventative medicine world, which is where I live, where if we apply a small dose in a preventative measure. I mean, I put people on copious amounts of fish oil who have heart disease in their family or Alzheimer's in their family. I mean, there's things I definitely do for folks where I'm like, I know you're not exhibiting this yet, but let's make sure that we don't drive those pathways. So in that case, I think there is a place for it in a little more broad scope. Over here, I think that folks there needs to be better support. It's just period. I mean, in the obesity medicine world and in the diabetes world, that we just need an overhaul. So no, I don't think it should be put in the water, but I don't think people need to be as terrified of it as the media is making it out to be.
Yeah. Well, we live in this time where everything has become so black and white, so inflamed, so polarized. And I do think that it's important to highlight the potential upside of certain drugs, I think that the past couple of years in particular have made people very skeptical of pharma, and for good reason.
Yes.
Just to be clear. But you see things all the time come out like, I came across a study recently on sildenafil, which is Viagra. And there was an RCT, a human randomized controlled trial, that found that it boosted muscle protein synthesis. There was another study that was published over the past few years that found that people who used it regularly seem to have a lower risk for Alzheimer's disease. So these drugs have these pleiotropic effects that are not all bad. And there's real suffering happening in the world. People are getting sick, even if you do all the quote unquote right things. I mean, you still can, I could still develop dementia one day. I hope not, but
you're training an army of us so that we'll take care of you.
Yeah.
We won't let that happen.
But it could, we don't have all the answers. So to have additional tools in the toolkit to fight against these kinds of conditions, that once you're diagnosed, there really is little in the way of hope. I think it's a positive thing, so long as we're accurately communicating the risks at the same time.
Sure. I think the risks are real. I mean, there's no get out of jail free card, but used appropriately. I mean, look at some of the other peptides. If you were to stack them and pump them all the time, would you be potentiating cancer? Maybe. I lived in the regenerative medicine space. We were pulling people's platelets out and concentrating them down and shooting them back into their joints. Some of my colleagues were shooting them into breast tissue to grow breasts bigger. That was a risk tolerance I wasn't willing to take because PRP is high in VEGF, and that's, metastases, metastatic tissue loves VEGF. So I wasn't about to shoot it into someone's breast tissue if I didn't know if there was a risk for any type of breast cancer. This was 10 years ago, and now here we are, and there's still really no risk. So it was just one of those things I personally didn't want to do in my clinic that other clinicians were. So there's risk anywhere, but we have to balance out the risk-benefit ratio of things. And then we have to look at dose. Dose is always a conversation that needs to happen in the pharmacologic world. These really aren't drugs. Again, they're peptides. But anytime we're doing anything, we have to look at dose. And I think the dose makes the poison in many cases. And people don't appreciate that. They just think, oh, well, this is the standard dose. We're going to do that. And I was pulling people out of massive tailspins during COVID by microdosing prednisone. I mean, I was putting people on baby doses of prednisone and just turning them right around, in addition to a few other things. Everybody was super happy and excited about the pharmaceuticals back then, right? I mean, it's like, what part of big pharma are we going to choose to vilify? I'm not saying you, but out there in the world, especially in the functional medicine world online, it's like, well, wait a minute, which part of big pharma do you not like and which part is okay? So I'm just kind of sitting here in the middle thinking, I'm here to help the person in front of me, and I have seen these have such profound impact on people very close and special to me that I'm sold. But I also realize we have 20 years of data on GLP-1s. They're safe. We're not finding any big problem, and that's at very, very high doses. So,
well, they're safe and quote unquote healthy compared to having untreated type 2 diabetes.
Yeah, which is
Are they safe and healthy, I think, is the question for somebody who doesn't have type 2 diabetes.
Well, I think it depends on dose. So, again, if basically my point is if very high doses of these or the standard dose has been considered over the long haul to be quite safe, then my little baby doses over here we're having a little bit different conversation. But again, I discuss all this with my patients and I'm really clear. And I wonder too, though, we're cranky. Some people say fish oil is going to kill us. Some people say that taking protein in a form that isn't chewable is going to drive up your insulin and so it's like, where do we draw the line? And I think that has to come down to the individual and what their risk tolerance is. And people really, like you said, people need to understand the real risk of type 2 diabetes. That's something that's been really normalized and underplayed. And there's a lot of industries that are, have something to lose. This peptide also is showing efficacy in wanting to help folks not drink or smoke.
I've heard, can you unpack that for us? I've heard that.
I'm seeing it.
I don't understand it.
I don't either. Well, there's dopaminergic pathways that are impacted. There is an impact on the HPA axis. There's serotonin pathways. I don't necessarily know why, but it definitely keeps people from wanting to drink too much. And I've got people messaging me saying, I quit smoking on it. I quit online shopping. My friend the other day said, I'm no longer doom scrolling. She was completely addicted to social media and she's just off of it. Like no issue. She's just like, I just don't want my phone around me anymore.
Wow.
So there's something with these reward pathways that's happening. And there's some big industries there that are probably concerned, right? And people are eating less fast food when they're on them, and they're eating less snack foods. And the snack food companies have come out and said they're concerned.
And they're shaking in their boots. Yeah,
and they've come out and said we're going to be creating a line of GLP-1 friendly snack foods. So remember like when the Atkins diet, all the crappy, like the Atkins diet's great, and then here's all the food bars and all that.
What is a GLP-1 friendly snack food?
I don't know. It's like it's going to go along with their GLP-1 lifestyle.
Wow.
So they're finding a way to market off of this, but the joint replacement companies, the dialysis companies, there's a lot of industries here that are profiting off of us being slow, sick, fat, and dumb. And I'm not saying everybody go on Ozempic, but the vilification of it and this frank, overt, like hatred for it that I'm seeing online, that's what really got me. I was like, there's too many benefits here for too many people. And bringing back up that fertility issue, and we are quite literally going extinct as a species. Most countries are not going to be able to repopulate themselves in a few years. Like we are really in a pickle as a species. And I think a lot of it has to do with metabolic dysfunction that's a big player in this. So if we can help folks there, I don't know the answer. It took us decades to get into this mess. I watched it happen over my lifetime.
Yeah.
But,
well, I don't see the food industry changing anytime soon for the better. And look, the food industry wants to create repeat customers and deliver delicious, hyper-palatable foods. I get it. Like if I were a manufacturer of a packaged food product, I would want the exact same thing. But I did have an interesting revelation or feeling. The other day I was in a restaurant and my server was very obese, morbidly obese. Which is kind of rare to see in Los Angeles. You don't actually see that much of that in Los Angeles. When I travel to other parts of the country, it's a lot more common. But it dawned on me in that moment that this is actually like, obviously it's my hope for every person struggling with their weight to change their diets and lifestyles as best they can and do it that way, right? But that's not feasible for every single person, right? I recognize that. And so it dawned on me that that obesity might one day be a condition of antiquity, that we might actually one day not see such, because it in that moment I felt like, okay, so we have these drugs available to us and this person is clearly morbidly obese. Maybe it's a choice. I don't know,
I don't think anybody wants to live like that.
I don't think so either. So I had this like thought. I was like, at this point, if we do have these drugs available to us as a fail-safe, and assuming this person has tried other diets that hadn't worked in the past for them, why would they not elect to take the shot,
right,
as a last resort?
Or I would even add something to that, in that, why are we waiting until it's a last resort? Like, why aren't we considering a lower, more appropriate dosage strategy like I'm proposing earlier? Because childhood obesity is a whole other conversation. I mean, I won't even get into that, but that's a whole other level of hell for these kids and what they're looking at. And it isn't there. I wouldn't say so much as, let's just blanket paint it. Oh, it's genetic. It's not genetic. It's not that simple. There's a lot of epigenetics playing into this. If the mom is obese, if she's metabolically unsound while she's pregnant, that fetus is swimming in insulin, bathing in high levels of insulin in the placenta. And that child is marked epigenetically to have a significant increased risk for obesity and type 2 diabetes. And we're several generations into this now. So we're looking at a very difficult position for humans. And so we've got that piece of the puzzle, but then we've also got folks who maybe I think about George Michael, the guy from Wham.
Of course, George Michael, icon.
Yeah, huge fan, right? Like, huge fan. I was devastated when he died, and I went deep searching. He died extremely obese.
George Michael?
Yeah, extremely obese. And they say he died of liver cirrhosis. So who knows if that was alcohol induced or was it fatty liver? Because a lot of folks are living with fatty liver and don't even know it because it's been completely normalized. Their doctors have fatty liver and they're like, oh, your labs came back normal and we've got some fatty liver here. And I'm like, it's not, fatty liver is bad. And that leads to cirrhosis and liver cancer. And we're looking at a massive epidemic of liver replacement needs here very soon. These people's joints are completely failing them at young ages. I mean, it's just on and on and on, right? And so that piece of it right there, I'm like, no, we shouldn't be putting Ozempic in the water, but also, oh my gosh, like, what is our plan? Like, what's the plan here? Because are we going to keep allowing this to potentiate in the way that we're just not going to, we can't obviously control craft and we can't control these big food companies. And so, yes, I'm all for policy change. And I know there's some folks on the internet right now saying we absolutely have to change policy. I completely agree. That is a slow, painful, uphill process. And who knows how fast or quick that will happen. We have seen our political system. It's very spicy lately. I'm over here like there's the frickin' house is on fire and I have a fire extinguisher and I'm going to use it. Like, that's where I'm at with this, is we have to do something because of that epigenetic marking and the fact that we're a few generations in. Have you heard of Pottinger's cats?
No.
So Pottinger was a veterinarian. Have you heard of Weston Price? You probably, okay. Dentist. So same time period. So Weston Price is touring the world and he's looking at degeneration from this Western diet, which was like so benign compared to the crap we're eating now, right? And he's writing nutrition and physical degeneration because he's seeing the changes in the dentition and the arches. And I know you know this, but just for the audience, like he was literally looking at indigenous peoples being fed the Western diet and watching their health deteriorate. And then Pottinger was looking at cats and he was feeding them, all he did was give them cooked meat and pasteurized milk. He did not feed them junk food. There was no junk food. It was the 30s. He gave them cooked meat and pasteurized milk. And within a few generations, their colons were boggy, their livers were enlarged, they were infertile, and it took multiple generations to get them back after putting them back on raw food.
But cats are obligate carnivores. So you're saying that the cooking of the food, just the cooked nature of the food?
The cooking of the meat and the pasteurization of the milk. The point is we are Pottinger's cats. We are this many generations into this. You know, it was the boomers and their convenience food, and now we're here, and it's only looking worse. I mean, the food supply since you and I were children is like, oh yeah, what happened to this thing we used to eat that is now this, right? It's a whole different ingredients list. So not that we should even be eating shit in packages with ingredients, but you know what I'm saying. It's not the same. And so my point being is this is going to take many generations to get us out of this. And we're in a pickle. So I'm proposing that we just consider that maybe the way this is being done, I really do think I bet you in 6 months, the medical establishment will start to catch on to what I'm laying down here.
Hope so.
And they'll start dosing lower and more appropriately, because I do think there's a place for these for a lot of folks who are on that tangent, and we've got a lot of overweight folks. We've got a lot of folks dealing with autoimmune disease. We've got a massive cardiovascular health epidemic, pandemic. We've exported it out. So I just think that I just don't want people to throw away the idea because it's been propagandized.
Yeah.
And I appreciate folks like you having me on to have my say, because I hate watching the media twist something up when I'm wondering who's behind that, right? And also seeing health influencers who have something to sell that might conflict, completely vilify this. I'm just trying to hold the line on common sense.
Yeah. Well, I do look forward to a day potentially where we might eradicate obesity and associated chronic disease. Because, I mean, you might choose to indulge. Now, I certainly do. I indulge, on a fairly regular basis. But nobody, it's informed consent when I'm choosing to eat the bagged, boxed, confectionery product or what have you. But nobody, I don't think anybody would choose obesity. Again, there's probably a very tiny subset of people that might, but maybe their partners are into it. I don't know.
That's a thing.
That is a thing.
I've had so many people message me and say, I listened to your podcast. My doctor was suggesting I try this. I tried it. My life has changed. But what a lot of folks are saying is, I feel normal now. This must be what you guys feel like you normal weight people who can eat when they're hungry and stop when they're full, or don't wake up ravaged. I've been pregnant before, and you wake up feeling like you're going to die if you don't put food in your mouth. You're so hungry, and it is very different than when you're not pregnant. And so there's something, and I remember having a partner who had some weight issues, and he was very cut and lean, but he had to work so hard at it. And I remember waking up and him telling him that and saying, I remember waking up pregnant like I was dying. And he goes, oh, that's how I feel every day. So having the onus of control, again, going back to that dopamine pathway and those reward pathways, there's something about it putting the onus of control back in the driver's seat. And I think that has a lot of implications for humans right now, because we're sort of we're all chasing the dopamine dragon for one reason or another, right? And it's just it's the way technology and everything else has just fired up our brains to we need the hit all the time. How many followers do I have? Am I gambling? What with fucking fantasy football? That is a thing. People have imaginary teams because that's their dopamine, right? And it's really, there's healthy versions and there's vices. We all have them. But then there's people who are really struggling.
Well, hunger is a real thing. And one strategy that has worked really well for me is to generally be cognizant of the degree of palatability of the food that I'm eating. And I try to avoid foods that are hyper-palatable. Mm-hmm. I'm not restricting myself, but I am aware that hyper-palatable foods tend to beg for their overconsumption.
They're crack.
Yeah.
I straight up I'm like, don't eat the crack. I'll say that to my husband. He's like, don't eat that, Tina. Or I'll say it to him, don't eat, that's crack.
Like a piece of lean chicken breast on it with a heavy cream sauce. I mean, suddenly you're making a lean chicken breast hyper palatable. But just by removing the sauce and using a dry rub spice instead, I mean, you're not making it any less tasty, but you are reducing the palatability to a degree that's going to make it less likely that you're going to want to overconsume that food. Yeah. And you could apply that to pretty much everything. I mean, you take a baked potato. I love to eat a plain baked potato. I'll sprinkle some salt on it. And, if I eat half the baked potato, I feel sated. Mm-hmm. I feel completely satisfied. The minute I start slathering on the butter and the sour cream and all of those different, the fats and the,
it's a boat of goodness.
It becomes a boat of goodness, and it becomes a lot more, the bacon, it becomes a lot more difficult to pump the brakes.
But you're talking whole foods in every case here. You're talking whole foods, right? I mean, most folks are not even eating whole foods.
Yeah.
If I'm eating rich chicken breast with a rich sauce, I can, even if it's hyper palatable, I can only eat so much of that.
Yeah.
The protein kicks in, the real fats kick in, they do their job. That's real food. It's whole food. But we're talking folks who are eating most of their meals out of packages or, getting them like Uber Eats or whatever, in tons of seed oil and tons of other stuff. And it's just, that's a tough one.
But I still think most people aren't really aware. They're not really aware of the fact that what you're eating influences to a significant degree how much you subsequently eat. what you eat influences how much you eat. And to think about it, to hyperfixate on how much you're eating, in a way, if you're not cognizant of the food quality aspect of things, you're putting the cart before the horse. You know, it's like you alluded to earlier. It's like if you're trying to moderate your consumption of the obesogenic diet that caused your obesity in the first place, you've already lost that battle.
You said once years ago that food is information, and that's, I've always I was like, yep, that's exactly it. So what information are you putting in your mouth in that moment over time? It's information for your body right at that moment too. What am I eating and how much of this am I going to eat? And it's a whole thing. I agree with you. I try to keep my meals really simple. It helps me with my gut isn't always happy. And so at least when I don't feel good, I can put my finger on what I ate.
Yeah.
I eat so simplistically that I'm like, it's boring. People always on Instagram are like, show us your food. I'm like, it's so boring. I'm not much of a chef. It's not very exciting. It's very simple ingredients. I try not to eat more than even whole foods, 3 things at a time. I want to know what I'm eating so that if I get a stomach ache or something doesn't agree with me, I can be like, I know what I ate, and I can go back the last 3 days and put my finger on it. And it's not the most exciting way, but to me, food has always been information. Food is just fuel. And I know for some people it's love and it's community and it's art and it's all these different things. It's not that for me. So I don't pretend to understand that world, and I don't want to speak for those people because I know for some of those people it's very, very challenging to stop eating. But you're right. Keep that hyper-palatability. Just keep it simple is what I say.
Yeah. But I also think there's a lot of our societal norms that need to be rewritten in light of current public health statistics. I mean, why does every celebration need to coincide with a cake or cookies
it's
or
sugar fest,
ice cream, or it's a sugar fest and a fat fest. It's both,
And sugar season, it starts in October. Well, it actually starts with watermelon in the summer, but then it starts with candy in October and it goes to the next holiday, to the next holiday. And every single time you enter a regular grocery store, it's first thing on display all the way up through Easter, until we get back to, school's out, so let's party again. It's just sugar season. So every October, I'm like, sugar season has begun. Yeah. Here we are. And the kids, I don't know. Kids are taught that's love. My mom used to take my daughter to Dairy Queen all the time for everything to celebrate. And I'm like, we don't need to be firing off her dopamine that way. Could we find a different way to do this? And that's a whole other conversation, I realize. But yes, there is a problem with how society views food, views celebration.
Yeah, I don't drink very often. I drink very seldom, but I'll still indulge in a good wine now and then. But I've stopped bringing over wine. It's a customary norm to, if you're invited over to a friend's house for dinner, bring a bottle of wine with you. I now bring a nice fancy bottle of extra virgin olive oil.
Oh, nice.
Because it's like a centerpiece for the table. It's so versatile. You can cook with it. You can
just drink it like I do.
Yeah, it's insanely healthful.
Oh, that's great. That's a great idea. I like that.
Normalizing healthy habits.
Well, and then going back to just even cooking at home, right? Just learn to cook. I'm not very good at it, but I do it. I mean, it's a necessary part of being healthy. It's just that's another non-negotiable. You have to prepare foods at home. Have
you ever seen these, it's called Kevin's Paleo Foods or something? Kevin's, they said I get them at Whole Foods. They now have them at Costco. They're like these sous vide pre-cooked chicken and beef with a little paleo approved sauce that it comes with. It takes literally 5 minutes to cook, and I've made so many dinners with this. I have no affiliation with the brand or anything like that, but it's just a really cool product. It's super easy to whip up. Nice. And it comes with a sauce that's doesn't have any added sugar. It's sweetened with I think a little bit of monk fruit, no seed oils, nothing. It's actually a fairly low fat product, very high protein, and it makes whipping up a fast dinner a breeze.
Yeah, I mean, there's options.
Yeah, so many. So if one were to consider using a GLP-1 agonist like semaglutide, what considerations would you make? Give us a protocol for how to utilize it for maximum benefit, least risk.
So that comes back to where do we start? And do we start with the semaglutide so we can get the person feeling better? That's one of the things that a lot of people are reporting is that they're feeling like moving. A lot of people will report once they start feeling better on these that they want to move more. So, and I've heard other doctors say that around month 2 or 3, people are much more interested in exercise and working out. So if we've got somebody who's at baseline doing nothing and it's like pulling teeth to get them to do something, am I going to withhold the semaglutide early on? I won't. I know some doctors would. But that said, the exercise piece is non-negotiable. I don't care what they do. Of course, we want them strength training. Like ideally, that's in an ideal world. But that is a skill that usually requires a coach. Not everybody has the means to do that. Some people have orthopedic issues. That was my whole world, was people with orthopedic issues. And so it's not readily available to some folks, or they don't know how to work around it because it was the strength training that got them hurt, So there's that piece. But they have to be exercising, and the data is showing that folks who exercise are actually able to come off these more readily and continue to have the weight loss success. So that's awesome. However, I'm not using them all for weight loss. So if I'm putting somebody on them, it's part of a comprehensive treatment plan. And so they've at the very least have to agree to be eating well. Like that is ground zero. That's non-negotiable. We're not going to be trying to put out a fire while somebody's pouring lighter fluid on it. That's just not going to fly. So getting people to understand what good proper nutrition is, whatever that is for them. I just want them eating whole foods. I want them trying to roughly hit 30 grams of protein per meal. I know we could do more if they're strength training. Of course, we want to more run that 1 gram per pound of body weight, but that's not feasible for everyone. Just start with a chunk of meat for your meal and work outward. You'll tend to eat less carbohydrates. You'll tend to eat less of everything else, right? So we want to make sure to prioritize that, make sure they're moving. I have to address sleep. Often I need hormones for that. Not being able to go to sleep is a progesterone issue. Not being able to stay asleep is an estrogen issue. There's adrenal issues to consider here. I usually have most people on some level of thyroid replacement therapy. I think thyroid replacement therapy is a beautiful longevity tool when used physiologically. I've been doing thyroid replacement therapy for decades, and there is also a joke that Dr. Tyna thinks everyone needs thyroid. I don't disagree with that. If you're a woman over 40, you probably need a touch. So
interesting. Is that a consequence of yet another unintended consequence of modern life, or?
That's a good question. And I think that takes us back to the GLP-1, because I've been thinking about this a lot. I think some people just, how are they coming to us, right? Like we can ask them to eat more protein and we can ask them to do all of these things, but how did they get here? What adverse childhood events did they have? What kind of stress have they endured? What kind of chronic illness have they had? What kind of gastrointestinal issues have they had? And so I don't know, because the thyroid's like the canary in the coal mine. So it goes down, but if it goes down, all systems are off and I can't get my work done. I can't get the rest of it to move. So I do, and I know there's folks out there who don't have a license to prescribe and they will sit there and bark at me all day about this, but I can prescribe hormones and they get it done faster. So I'm always going to support adrenal glands, always, always. You can't support the thyroid and not support the adrenals because they'll bonk. So it's a hierarchy, right? And we go into it by layers. GLP-1's somewhere in there. That may not be the first thing I grab. It might be. It depends on, do I need to get this person motivated to move, or do they have a lot of pain? Are they having a ton of brain fog? And it's just overwhelming and anxiety driving to have to chop vegetables and they can't even fathom it, the overwhelm's too much. Are we sitting in a really precarious spot with insulin resistance? What are we going to pull out there, right? Are we going to throw a little metformin in there? I certainly don't think people need to be dosed the way that they are dosed in the standard model there either. So I use the tools I have, but hierarchically it's dietary. We got to get them eating well. And then whatever, do I need to give them some adrenal support to give them the energy to eat well and make better choices, and on it goes. But sleep is way up there. We have to get that dialed in. Otherwise your metabolic health is a disaster. You've seen any of that data, like sleep deprive them for hours, days, weeks, they fall into metabolic dysfunction.
On one night of poor sleep, you're essentially pre-diabetic the next day.
It's a temporary fast track, right? But so you're in it. So we have to address that piece. And like I said, that's multifactorial. So wherever it is in there, and then the GLP-1 to me is like the sweetener. It's just a little sweetener on top. And I think of estrogen that way. I think of testosterone that way. I really like to clean up the terrain before I throw those in. I don't want to throw testosterone into an inflamed male or female, for that matter. A female may need a little touch of testosterone too.
I'm hearing that more and more.
Yeah. I mean, I've been talking about that for years, and I think it's finally catching on because it's a really great pain mitigator, but it will convert to estrogens depending on their aromatase activity, which is contingent on their belly fat, right? So we have things we have to look at, and I don't want to put those into a totally inflamed hot mess. So we kind of got to clean up the hot mess of inflammation. Beautifully, GLP-1s seem to do that. So that's where I'm starting to lean, like, do we pull these out earlier? This is kind of a beautiful adjunctive therapy regardless of where we are in this hierarchy. Depends on how we dose it and, how we're putting it in there. But if I can give somebody hope back and an onus of control, I have never seen anything work like this peptide does in that capacity. It just normalizes the playing field, and they're like, oh, I can think, and I know what to do next, and I know what my next best move is. So that's kind of how I go about doing it.
Is this drug under what, in what circumstances is it covered by insurance,
I don't, because I've never taken health insurance, and I don't play in that world. But from what I'm hearing, I did try to get coverage for my dad, and it was a pain in the ass. And so, it was ridiculous. Like, he is significantly overweight and totally would qualify. And they were like, no. And it's just been cleared for cardiovascular health. And my mother-in-law went in to talk to her primary, and they were like, no, it's just for weight loss. You don't qualify. It's crazy. She's, it's just crazy. So they will. And again, I think that starting dose may be too high for a lot of people. So what I'm hearing is they get X amount of months and then it's pulled. And I think that's a devastating way to do it. They're looking at it as this short-term Band-Aid. I'm looking at it as a preventative healing modality. So it's a very different approach. And so I would potentially cycle it like I would other hormones so that we don't get receptor resistance. I want to be able to keep the dose as low as possible. So I don't ever want to crank it up and just keep them on it. So I would cycle it much like I cycle testosterone, or I would even cycle thyroid hormone sometimes. I think seasonality plays into it. I see differences in my patients' hormonal needs based on the season, especially thyroid, depending on where you live. I live in Oregon, so we have 4 real seasons, and thyroid needs change there too. So I would consider that. I might rotate it out with tirzepatide. I might pull in tirzepatide for different reasons because it seems to have a better impact on weight loss and a better impact on metabolic function. So kind of depends. But I do believe that more doctors are hearing me. I have a course that doctors are taking. Half the people in there are doctors and half are the general public. And the doctors are starting to get it. I'm hearing from more and more clinics that they're starting to offer low dose or microdosing. I don't know how they're doing it. I don't know what they mean by that. I don't know what else they're doing in there. But I think the idea of just maybe a more appropriate approach would be, these functional medicine communities, I think, are hopefully starting to catch on as I go around trying to spread this message.
Yeah. Well, anything else people need to know?
I have a bunch more education about it on my podcast if folks are interested. I break down different studies. I talk about it in relationship to different conditions in particular. So I think that's, depends on what people's cup of tea is. And then I have a 4-part video series that people can find on my website that's free, that dives into some of these things in a deeper way. And yeah, I'm going to just keep digging and see what I find, because it's pretty exciting. Yeah,
well, it's a breath of fresh air because, we live in not to beat a dead horse. Everything's just become so polarized today, and I think it's really important to be able to have a nuanced conversation about these tools, which they're tools,
Yes.
And like any tool, like fire can be used to cook your food or to burn you.
Yes.
And it's about how we use these tools that makes them either helpful or harmful, and yeah, so I'm glad we have them at our disposal. I've had chronic disease in my family, and if there were that silver bullet pharmaceutical that would have helped, I would have been first in line to fill that prescription. So I know that there are, lots of people out there that are really suffering, and yeah. So again, as a fail-safe, as a last line of defense, or even for some of these, with these other disease outcomes, I think it's really, I'm optimistic. So thanks for coming on and sharing the science.
Yeah, thanks for having me. And thanks for being open to this conversation, because you're right. People are really polarized and some people don't want to hear it. So thank you for being open-minded.
Of course.
Always.
Yes, always. One last question for you before we get to that. Where can people connect with you on social media? How can they support your work, learn more, etc.?
Yeah, so I'm at Dr. Tyna. It's DrTyna. I'm on Instagram, I'm on YouTube, and that's my website. So drtyna.com, and that's where my podcast is, and more information about these peptides and more information about me. So
dope.
Yeah.
What does living a genius life mean to you?
Oh, that's a good question. I didn't know I was going to get hit with this one. What does living a genius life mean to me? You know what? I'm a smart cookie, and I have always prided myself in my brain power and my ability to distill bullshit, but also to think fast. And so maintaining my health is it. Like, that's my genius, right? And my genius truly lies in my ADHD and my just ability to sniff out and move fast and do different things at once. And that's all tarnished when my health is compromised. And I've had really, really difficult issues with my health over time. So for me, it's just maintaining that level of wellness so that I can be my optimal me, so I can help as many people as I can help.
Yeah. Amen. I love that. Well, thanks, Tyna. Thanks for coming in.
Yeah. Thanks for having me.
Yeah. Hey, if you liked that video, you need to check out this one here, and I'll see you there.